Welcome back to Clogs and Cancers, where we talk tubes, tumours and toilets. I'm Dr. Feldman, your friendly neighbourhood urologist and part-time VCUG whisperer.
And I'm Tony, ex-urologist, full-time plumber. I've snaked through more pipes than you've scoped ureters. But hey, today's topic is one I remember well. Vesicoureteral reflux, or VUR, for those of us who don't like tripping over Latin.
That's right, Tony. VUR is when urine flows retrograde from the bladder into the ureters, and sometimes even up to the kidneys. It's like plumbing with no backflow preventer.
So what's the deal? Is it a valve problem?
Exactly. Normally, the ureter tunnels obliquely through the bladder wall, creating a flap valve mechanism that closes during bladder contraction. In primary VUR, this tunnel is too short or poorly formed, so it doesn't close.
So it's like a poorly soldered pipe joint. Got it.
Then there's secondary VUR, usually due to elevated bladder pressure from obstruction or dysfunctional voiding. The valve gets overwhelmed and refluxes. The gold standard for diagnosing VUR is the voiding cystorthrogram, VCUG.
Ah, yes. The test where we fill the kid's bladder with contrast and watch what happens when they void. Nothing like being told to pee under fluoroscopy.
And don't forget renal and bladder ultrasound, RBUS. It can show hydronephrosis or scarring, but it won't detect VUR itself. Grades matter, and not just for medical school. VUR is graded 1 through 5, Grade 1, reflux into ureter only. Grade 2, into ureter and renal pelvis, no dilation. Grade 3, mild dilation. Grade 4, moderate dilation, blunting of fornices. Grade 5, gross dilation, loss of papillary impressions.
So I2 is like a leaky faucet, 3 is a dripping ceiling, and V is a busted main line.
Here's where it gets clinical. Most low-grade VUR, 1 to 3, will resolve spontaneously, especially in younger kids.
So we don't rush to fix it?
Nope. Instead, we use antibiotic prophylaxis, usually a daily low dose of something like TMP-SMX or nitrofurantoin, to prevent UTIs while we wait for resolution.
Any evidence it works?
The RIVER trial showed a 50% reduction in recurrent UTIs with prophylaxis, especially in high-grade or recurrent UTI cases.
So when do you break out the tools?
Indications for surgery include persistent high-grade reflux, grades 4 to 5, breakthrough febrile UTIs despite prophylaxis, renal scarring on DMSA, parental preference or non-compliance. We've got two main options. Open reimplantation. Cohen cross-trigonal technique is the classic. Endoscopic injection, deflux or similar bulking agents.
So open is the copper repipe, and deflux is the patch job. Got it.
Exactly. Open has a higher success rate, approximately 95%, but deflux is less invasive and still boasts approximately 70% success for lower grades.
So how long do we keep these kids on antibiotics?
VUR resolves on repeat. VCUG, often done approximately 12 to 24 months after diagnosis. The child gets older and more toilet trained. Risk of infection drops. Or after successful surgery. We often stop surveillance once VUR resolves, the child remains UTI-free, and kidney function is stable. VUR can lead to recurrent UTIs, pyelonephritis, renal scarring, hypertension, CKD in severe cases. It's also often associated with bladder and bowel dysfunction, BBD, duplication anomalies, posterior urethral valves in boys.
So if you're seeing VUR, you gotta check the whole plumbing system.
Here are some quick pearls. VCUG equals diagnostic gold standard. Grade 1 to 3, observe plus antibiotic prophylaxis. Grade 4 to 5, or recurrent UTI, surgical evaluation. Surgery options equals open reimplantation or deflux injection. Watch for renal scarring, HTN, and BBD.